Going to get us underway. It's right at 12. I am very pleased to introduce our speaker today, who I've had the pleasure of knowing since 2005. Dr. Stephen Hanson is Associate Professor in the Department of Philosophy at the University of Louisville and is the Director of the Interdisciplinary Master's Program of Healthcare Ethics there. He is an outstanding teacher and researcher who recently won the prestigious Art and Science Distinguished Teaching Award at the University of Louisville. Dr. Hanson teaches and publishes in the areas of clinical ethics and end-of-life care and death and dying and theories of medical ethics. Dr. Hanson received his BA in philosophy at Rice University and then completed his PhD in philosophy at Georgetown University. He later completed 2 fellowships at U of L, the Crown Life Fellowship in Bioethics at the Institute of Bioethics, Health Policy and Law, and the Gaines Foundation postdoctoral fellowship in bioethics the previous year. Dr. Hanson is a member of U of L's Institutional Review Board's vice chair of the Ethics Committee and is one of the founding members of the MA program there. He has an appointment in family and geriatric medicine and that has allowed him to round with residents and learn much about clinical life in and out of the hospital. He has taught in bioengineering, public health, dentistry, and has taught multiple didactics and small groups in the ethics portion of the School of Medicine Introduction to Clinical Medicine. He collaborates with the geriatrics faculty in palliative care in their palliative care fellowship in the hospital. His talk today is Justice in Distribution of Scarce COVID-19 Resources, or Why Zeke Needs to Get Woke. Let us please give Dr. Hanson a warm welcome.
Thank you. If everyone can see, I'm sharing screen, so hopefully everyone can see the PowerPoint that I've got, and I will, and hopefully everyone can hear me. So I'll begin. And we'll start with, unfortunately, we have to start with very basics here. The United States doesn't have any kind of clear federal policy for how to distribute scarce medical resources in COVID-19 or anywhere else. I think partly this comes from the fact that we've been insulated from the impacts of a lot of natural disasters by wealth and other factors, but it also comes from a historical unwillingness to make difficult medical ethical decisions based on questions of justice. Won't argue that here. We can discuss that in questions if you'd like, but I think it's pretty clear that we haven't developed our discussions of justice nearly as much as we've developed our discussions about, say, informed consent. Distribution of solid organs for transplants, one of the few areas where we've really carefully thought about it. And if you look at our policies for distribution of solid organs, they're almost entirely unique in how carefully thought out and complex their distribution mechanism is. So when we talk about distribution of scarce resources in something like COVID-19, we're at a really basic stage. We need to start with things as basic as what are the basic moral concepts we ought to be working with. If we look at some of the other scarce resource distributions that people have talked about, you can see that a common thread results, and that's basically produce the best results in a utilitarian fashion. Alistair Brown, talking about distribution of blood and blood shortages, says allocate it to patient on the basis of who has the best chance of maximum life extension. And he develops a point system to include things like survival to discharge, comorbidities, age of patient, and so on. Philip Rosoff talks about in cases of short-term drug shortages in hospitals, the foremost criterion for giving one patient access over another would be demonstrable evidence of therapeutic effect. When we talk about military triage, where the number of patients might quickly overwhelm the routine medical assets available, patients with the greatest chance of survival with the least expenditure of time, equipment, supplies, personnel are to be treated first. And so you see, it's a pretty common viewpoint to say when we're talking about distributing scarce resources, we take as for granted, here's the policy we should be thinking about: save the most years of life or the most lives and proceed from there. Now, if we follow this account, then when resources are truly scarce, we should treat those most likely to live the longest, and that would mean avoiding treatment of the sick and the elderly. Doesn't mean you would avoid palliative comfort care, but you would not grant them access to the scarce resources. You probably would also treat clinicians, because if cured or vaccinated, they can continue to provide care. And you see that in the CDC allocation guidelines for pandemic influenza vaccines. Look, there's a reason why this line of argument is common. It makes sense, at least on first glance. It's not only practical, but ethical. It has an element of fairness inherent to it. Certainly when you put it against views like, whoever's the wealthiest gets to, whoever can pay the most for the scarce resources, or whoever has the best insurance or something like that. I mean, this position seems obviously superior to those sorts of things. And on its face, it appears neutral to things like race, gender, wealth, and so on. Because all that matters is whether and how much the recipient will benefit from the resource. And it also seems better than other inequity blind methods of distribution like lotteries, which would give you very inefficient, or could give you very inefficient distributions. So when Philip Rosoff, one of these authors, says, look, here's the minimum criterion for fairness. It must be to treat people the same who are similarly situated, in this case, clinically situated. When you say that, that seems basic and inarguable. But the problem with this approach is that, contrary to the initial oppression of inequality blindness, it isn't. It privileges the powerful, and it unequally harms those who are least well off. Look, we know this magnifies social inequality. In every civilian disaster, those who are already disadvantaged suffer the most. You saw that in Katrina, when people who were poorer they were less physically mobile than those with more money, both from access to vehicles, but also familial or community ties to the neighborhood, or maybe just they were mobile, but their elderly parents weren't. All kinds of things kept less affluent people from evacuating in cases of danger. And in cases of COVID-19, the increased risk is going to come because socially disadvantaged persons are already going to be less healthy. We know this, right? I mean, this isn't hard. Multiple assessments of social determinants of health make it really clear. People who are poorer financially have poorer health. They have fewer resources available, they die sooner, they have more comorbidities and so on than those who are wealthier. And honestly, we also know why. Here's a picture from Mossville, Louisiana. This picture's about 15 years old now. Stop using it when it stops being correct. This is, if you know anything about Mossville, and I don't know why you would, but it's one of the suburbs basically of Lake Charles, Louisiana, and within about a 10 to 15 mile radius of this woman's house, there were about 20 different chemical plants, most of them making polyvinyl chlorides. And each of those plants has a certain number of parts per million of various contaminants that they can release on a daily basis without having to, announce it or do anything other than that. So it's not then a tremendous surprise that she's in this neighborhood having problems with contamination. And by the way, when Laura hit just not long ago, hit Lake Charles, one of the big problems was it did some damage to at least one of the plants, and they were under basically a duck and cover warning. It's a shelter in place warning for I don't even know how long it took. It was over 36 hours that anybody in the area was supposed to be basically hiding inside an interior room because there was way too much contaminant being sprayed out. So of course, if this woman comes in with a COVID-19 diagnosis, she's going to have additional comorbidities, and she's going to be than somebody who is from an area that doesn't have this same level of contamination. Although she won't come in with a COVID-19 diagnosis because she died of a cancer, which is linked to dioxins, which are produced by polyvinyl chloride creation, although because they couldn't prove her cancer came from proximity to the chemical plants, she and her family didn't get anything from a lawsuit. Also, I believe the house didn't sell. So we know in the US that persons who are poorer are going to have poorer health and more comorbidities. And we also know that the same is true of persons who are non-white. And these factors don't just add with each other. They actually, if you're poor and black, it's not just the troubles of being poor plus the troubles of being black, they actually multiply each other. So for both socioeconomic status and ethnicity, being less well off correlates with being less healthy. And I'm not a Rawlsian, so I can say, you don't have to be a Rawlsian to say this is something that we've got to pay attention to, dealing with those who are least well off when we're trying to figure out how to distribute scarce resources. So the claim that Rosoff made, the primary criterion for fair selection is similar clinical situation, that ignores the crucial issue that those who are previously disadvantaged are not going to be in a similar clinical situation. And so they're not going to get the best results from a scarce resource. Consequently, this fact that appeared to be basic and inarguable is also wrong. The minimum criteria for fairness can't be just similar clinical status. It's got to include some assessment of inequality headed into the need for the scarce resources. We have to pay attention, in other words, to who was the worst off before disaster struck. That was a long time before I get to my thesis statement, but let me say, here's the basic argument. The ethical analysis of possible policies for allocations of scarce resources in COVID-19 or any disaster or mass casualty has to take into account matters of justice. We have to reject methods that attempt to maximize results while ignoring prior inequalities related to ethnicity and socioeconomic status, because these are the greatest social determinants of health. If we ignore those prior inequalities, we're going to unjustly exacerbate the inequalities in society. And again, we'll do this at a time of high stress when abuse of power structures in society will be likely more common. Okay, that's talking about just distribution of scarce COVID-19 resources, but why does Zeke need to get woke? I want to focus here on a particular article by Zeke Emanuel and his group. This is the March 23rd article in the New England Journal of Medicine. And I want to focus on this relatively early article for a number of reasons. First of all, it's highly cited. When I first wrote the words highly cited, I looked it up, 458 citations. 3 days later, 467. This morning, 471. It's not only highly cited, it's continuing to be cited. This article is influencing the discussion about what we should be doing with scarce medical resources, and it's influencing it significantly. That's actually going to be a major point in my argument. Emanuel and his group have recently published some positions that are somewhat more amenable to some of the arguments I'm going to make here, but this is the article that's defined the conversation, and that's why we have to pay attention to it. And that's a lot of names up there. Why is it Zeke? Well, I focus on Zeke Emanuel as my main target because dang it, he's Zeke Emanuel. I mean, Govind Persad, the second author, has been working for decades on scarce resource distribution, but it's not, no, it's the E.J. Emanuel tag that gets the eyeballs on this. And, someone once said, with great power comes great responsibility. And yes, it was Spider-Man's Uncle Ben. But the point is, when you're right, whether or not you're a comic book. Zeke Emanuel has a responsibility to publish in a way that will promote justice because he can. And I'm going to suggest they don't. The recommendation of this group in this article for resource triage is to distribute resources with the aim of maximizing benefit, generally in terms of maximizing years of life saved. In a recent article in Science, they qualify what they mean by that. They use a label, standard expected years of life lost, SEYLL, basically comparing how many years of life somebody would have had if they'd continued living, compared not to their lifespan in the country or the city that they're living in, but a standardized version of that. And they give some reasons for that in the article in Science, but for here, purposes, they're trying to maximize years of life saved by where they distribute scarce resources. And this policy, and any policy like that, is going to unjustly exacerbate inequalities in society, because even though it looks like a universal program designed to provide a universally valuable resource, scarce medical resources, equally to all persons in society, it noticeably fails to do so in actual practice. And a policy that's going to be like that, that's going to treat different groups differently, then in order to actually be equitable, it can't be universally provided. It has to be targeted in order to produce a more fair and just effect. And this is a practice that John A. Powell calls targeted universalism. Powell intentionally doesn't capitalize his name, so that's not an accident there. But he uses the Interstate Highway Act in 1956 as an example of a policy that needs to be targeted and wasn't. Presumably, when you talked about interstates, this is a resource that would benefit everybody. The mobility granted by interstates would apply to everybody who drove, and if there weren't as many cars in 1956 as there are now, well, people also used interstate bus transit or benefited from the results of interstate commerce. So it was supposed to be, I would assume, a universally valued program. But notice what they did. Interstates displaced, surrounded, damaged downtown neighborhoods at the same time as they created easy access to suburbs, which enabled decades of white flight after Brown versus Board of Education, which again is 1956, same time. The result of a system that at least ex ante looks like it would provide a universal benefit actually ends up benefiting groups quite differently and very much according to racial and socioeconomic differences. So if a public policy, and this is Powell's argument, but he's right, if a public policy is to be truly just, it has to avoid the illusion of universally equally effective policies that in fact distribute benefits very unequally, especially if those unequal distributions tend to disproportionately disadvantage those who are less well off. And we have data now to show what Emmanuel and his group surely knew before they wrote this. That's exactly what rationing according to maximizing benefit will do with COVID-19 resources. How do I know this? Well, I mean, we all know this. The numbers have shown continually an absurd overrepresentation of minorities in COVID infections and COVID deaths, and this shouldn't surprise anybody. I mean, it's predictable. Part of that predictability is we know the reasons for this. The factors that make you more vulnerable to COVID-19 and COVID-19 related complications, they're not evenly nor fairly distributed across society. Comorbidities that are problematic for this sort of thing are overloaded in persons of lower socioeconomic status and minority status. In the United States, rates of smoking, diabetes, overall poorer health, these are higher in persons of lower socioeconomic status, Native Americans, African Americans. And these are the factors that will tend to make somebody less likely to benefit from a scarce resource. So if we distribute scarce resources by a purely utilitarian analysis, then what we're going to do is going to prefer those who are already socially advantaged. And what's more, we also know that being in positions that make COVID infections more likely, they're not evenly distributed either. The ability to do what we're doing right now, the ability to work from home, as opposed to having a job that requires your physical presence, especially physical presence with interaction with the public in a service industry. The ability to take a day off when you feel sick without loss of pay, or perhaps more importantly, your coworkers' ability to take a day off without loss of pay when they feel ill. The power to act on dangers that you foresee. These are all things that are not distributed evenly across our society, and they really aren't even close. I mean, at U of L, at the University of Louisville, we had a lengthy discussion about what to do if a student came into class not wearing a mask and refused to put one on. And remember, this was a political statement not long ago, maybe still is, to not wear a mask, and there was some significant reason to fear that this might actually happen, and the solutions weren't great. One was even cancel class and avoid contact that way, which is hardly an ideal solution. But notice that's something that a professor can do. And you can control your contact in a much more dramatic fashion than, say, someone stocking the shelves at Walmart can. So of course, COVID infection rates are higher in communities of lower socioeconomic status. This is obvious before we even collected data. And the reasons for why this is true their socioeconomic status, their race, and their history. Clyde Yancey, writing out of Chicago, points out where and how Black individuals live matters. If race per se enters this discussion, that is the discussion about who's getting COVID-19, it's because in so many communities, race determines home. And the reasons for that go back generations, and it doesn't take too many generations before you get to explicit redlining, which determines where you could live. And non-explicit redlining is still true in lots of places. So this plays out very much so in who gets COVID and how dangerous it is. So Emmanuel and his group are writing in March 23rd. Well, in April 2020, Yancey points out 50% of the COVID-19 cases in Chicago and 70% of their deaths involve Black individuals, who make up about 30% of the population. Moreover, those deaths were concentrated mostly in 5 neighborhoods on the South Side. You saw it at about the same time in Louisiana. 70% of the deaths were African American, only about 32% of the state's population. You see similar numbers in other states. And what struck me was how clearly we can see that over and over again. We saw it in Louisville in a very particular way. We collected data on the first 700 hospitalized cases of COVID-19 in Jefferson County, which is the heart of Louisville. These show the same data, and we have a little bit more that we can do with it. This comes not from April then, but from the end of June. Here's our data on the first 700 hospitalizations. If you look, there's only about 54% of our hospitalizations were among white people. Jefferson County is over 70% white. It's about 24% African American, and here they had 32% of the hospitalizations. So we saw what everybody else was seeing, not just in our cases that were cases of COVID, but in fact, in cases which were serious enough to be hospitalized. We had rich enough data here that we were able to produce some heat maps that really make this connection clear. I want to show you kind of what we came up with. Here's the first one. Since we had data on exactly who was hospitalized and things like where they lived and so on, we were able to create a heat map of where these cases came from. And you can see the clear circles that were drawn show much higher risk of infection of COVID-19 in these various circles here. This area here is the river, so there's nothing that goes on beyond that river there, but otherwise, this is the area of town and these specific areas where many, many of our infections that were bad enough to get to the hospital came from. Now, there's no special reason why you should know this other than maybe Dr. Dukas. He's probably already nodding his head here and saying, I know where this is going. When we take these same circles and instead of putting a heat map of where the infections were, we put a heat map of who lives in those areas, well, it's not terribly surprising. This is the same circles of heightened risk compared to persons of Black or African American race. And you can see where they were is exactly where the highest risks of COVID were. And the same kinds of concerns show up when we map this against not race, but poverty. Now, this is unpublished data. One of the flaws of unpublished data is, well, upcoming. This is an earlier graphic with slightly different circles and slightly different numbers attached to those circles being drawn, but you can see it's basically the same thing. Here's where persons living in poverty are, and again, that's the heightened area of risk for COVID-19, serious enough to get into the hospital. And just in case there was some question, we thought, well, again, what's one of the things that's really important in determining whether or not COVID-19 is serious enough to get to the hospital? Age. So we put a heat map of where people who were over 65, where they lived in the Louisville area, and you can see that doesn't line up at all. the thing that we think is the biggest risk of needing hospitalization for COVID-19 isn't. It's not age, it's poverty, and it's race. And what we've got heat maps for Louisville for is what we've seen across the country. Being less well off means higher risk for having COVID and serious COVID. Which brings me back to Zeke Emanuel and his March 23rd article. Let me just say, I'm angry with Zeke Emanuel and his group about this. This is not a mere philosophical dispute here. I'm angry because this was maybe our one good chance to start this debate by making a good argument for improving rather than worsening the inequality in America. And they threw it away instead to argue for a position that'll maintain or even probably increase inequalities. And we knew then, what we have data for now, that the burden for COVID-19 was going to fall more heavily on the poor and persons of color. We knew that. And Zeke Emanuel is in a unique position. He can publish in the New England Journal of Medicine at will. And he could have used that space to do something good. And he didn't. Instead, he did, well, what did he do? If I'm going to be upset at him, I better be able to explain why I'm upset. What did they argue? Well, here's what they argued. They said, here are the values that we ought to use to guide distribution of scarce healthcare resources. I apologize for this, but it's not mine, it's theirs, but I'll try to highlight a little bit. It's a bit of a complex slide, but I'll try to highlight what they're talking about. They said, look, we want to pay attention to maximizing benefits. And they not only pay attention to it, they want to say, this is what is the most important thing that we ought to be paying attention to. So far, doesn't make them unusual. That's the problem, of course. But they add to this things that should help the situation, but don't. Say, look, we also want to treat people equally, not by, and they do say, no, we don't want to do first come, first serve. That's not a good way of treating people equally. But we do want to treat people equally, that when they have similar prognoses, we treat them equally, and do that by a random selection. Now, random selection is a way of providing equal treatment to persons when you don't have enough. So that makes sense. But the problem is it's only amongst persons with similar prognoses. And as we pointed out, persons are not going to have similar prognoses because of things which, again, are not under their control, social determinants of health. They also note they want to reward instrumental value. The main point of this is giving priority to healthcare workers. Though it does, again, when maximizing benefits work along with this, they say, okay, we'll also give benefits to research participants. And then finally, down here, give priority to the worst off. Why do I say finally? This isn't a lexical ordering of these things. Here are the 4 things that they value. Well, I say finally because look at when it matters. Used when it aligns with maximizing benefits. You only pay attention to giving priority to the worst off after you've done all the rest of this. Well, this is a bit of a complicated slide. Let me go ahead and try to rephrase this slightly. So here are their priorities. Maximize benefits, provide equal treatment for people who are equally situated, reward benefit to others, and then, but only then, pay attention to who's worst off, and only when that maximizes benefits. Now, there's nothing wrong with any of these. These are all moral priorities that are valuable, but notice what's at the bottom. You only pay attention to who's worst off after everything else is taken care of. And then what they talk about as being worst off is they do discuss being the sickest, but they pay more attention to who's the youngest. because those who are the youngest who are ill and then die would lose the most years of life. And this is a problem with how he describes the worst off, even in his latest publications. In other words, they don't discuss what makes one the worst off in your continuing health situations or your continuing healthcare situations at all. And I think this is the major problem here. They're treating the pandemic as something which has come into the world as if there were a vacuum before it. They're looking at issues that are occurring in a slice of time, but not what came before it and not what's going to come after it. And they need to look at, in particular, who is the worst off in the context of a continuing picture, but they don't. So if those are their priorities, their recommendations are unsurprisingly insensitive to the concerns that lead people to be in the conditions they're in. They recommend 6 things. First, obviously, maximizing benefit. The second, they do want to distribute things like PPE, testing, vaccines, ICUs, basically anything that might be needed, should go to clinicians and frontline healthcare workers because that will end up enable them to help other people. And they again say random distribution for patients with equal prognoses. There are 3 more things they talk about which might help justify, might help give them some grounds for saying they are actually paying attention to the worst off. They say we're going to distribute different modalities differently. Now, this is actually a good point. Vaccines are prevention. ICUs are treatment. We shouldn't be distributing them the same ways to the same people. Treatment would benefit people better if it goes to younger people with fewer comorbidities, whereas vaccines would tend to benefit people better if it prevented them from getting sick, the people who would lose most from getting sick. So vaccines would be distributed to persons who are older or persons with more comorbidities. This might actually be something which would help them say, here's how we're paying attention to the worst off. I'll tip my hand, I don't think it does, but I'll have to explain why. Then they have 2 more recommendations, which are relatively mild. If you're a research participant, that gives you a tiebreaker status. And they do say we should be paying attention to all persons who need scarce resources, no matter what they need it for. So no matter why you need an ICU or a ventilator, you should go into the pool to see whether or not you end up with it. Well, why don't I think this helps? Maximizing benefit is their first priority, and we've already explained, I think I've already explained why that's not going to actually benefit those who are least well off. It benefits, and it's something that makes sense to pay attention to, but it's not going to help the least well off. Recommendation 2 is basically another extension of maximizing benefit. Again, not a bad thing to do, but it's not going to be something that actually ends up benefiting the least well off, nor does research participation. If you know anything about getting groups into research, it is in fact a challenge to get people of lower socioeconomic status and persons who are African American to enter into research for reasons that, again, are historically pretty plausible, but they're not going to help them in this situation. Nor is it going to help to say we should pay attention to all your needs for scarce resources, because again, the persons who are least well off, well, they're least well off. If you need a ventilator because you have severe COPD, that's going to put you into this same mix. It's not going to benefit you, just that you, even if you don't have a COVID-19 diagnosis. So none of those are going to benefit persons who are the least well off. But what about these last 2? I think 3 is supposed to. I think recommendation 3 is supposed to give us an idea of equal treatment, but it obviously doesn't, because those who are wealthier and whiter will be, and as we've seen from the data, are, as a population, healthier. And so treatments are not going to be randomly distributed between them and poorer persons and persons of color, because they're going to be less well off. 3 is going to absolutely fail to provide any kind of preference for, or indeed benefit to, persons who are least well off coming into it. But what about the 4th one? Remember, that said Treatments in ICUs maybe go first to people who have fewer comorbidities and who are more likely to benefit from being treated. But vaccines will go first to those who would benefit more by not getting sick. And that would be persons who are less well off, either by being older or having increased comorbidities or any other reasons. So you would think this might help benefit the persons who are less well off. But now we have to remember when this came out. This is March 23rd. At that point, vaccines are a pipe dream. They're long in the future and nobody knows when in the future. So this is 4 is showing up not in the presence of a vaccine, but in the absence of one. And in the absence of a vaccine, all this means is that the persons who are getting ill the most are the ones who are less likely to receive whatever treatments we happen to be rationing out. And again, this is an article that talks about vaccines, but is very much an article about distributing scarce treatments. They know this. Basically, their concern is unless the epidemic curve of infected individuals is flattened and over a very long period of time, COVID-19 is likely to cause a shortage of hospital beds, ICU beds, and ventilators. That's a quote. That's their main concern in this. Even this, where we distribute vaccines, isn't going to benefit the least well off until we get vaccines. And oh, whoops, not then either. Because the first millions, tens of millions of doses of vaccines are going to go to clinicians and frontline healthcare workers. Persons who are least well off are not going to end up being distributed in any way that benefits them for a long time after that begins. That's their 6 recommendations, and that's how many of them actually benefit persons who are least well off heading into a COVID-19 pandemic. It's worth mentioning, though, why they think that we should look at this way. They do talk about their reasons for maximizing benefit as their primary goal. And they talk about it as stewardship of scarce resources. Their concern is that clinicians would have trouble working if they don't know that the resources they're using would be well spent. The specific quote is, "It is difficult to justify asking healthcare workers and the public to take risks and make sacrifices when they know that their efforts to save lives and lengthen lives is illusory." Well, illusory is kind of silly. If you're providing healthcare to anybody, you're helping lengthen and support and save lives. But I assume what they mean is not illusory, but rather not well distributed, not efficiently distributed, not responsibly stewarded. Which is kind of silly, or at least kind of surprising for Emmanuel to say, since he's written extensively on the ongoing waste in the American healthcare system. He knows full well that we have a, outrageously expensive, grossly inefficient, and error-prone system that we're working in. And yet we've still managed to keep working, even though we're not perhaps responsibly stewarding the resources as well as we could. I think actually what he means is this. It's not that clinicians wouldn't be able to work if they weren't making the best use of resources. It's that they wouldn't be able to work well when, and I think there's a reason to think this, they cite a ventilator distribution policy by the New York State Task Force. Maybe the idea is with clinicians are seeing patients they could be treating but can't, dying for the lack of resources, then they would have trouble doing it. And I believe that. I believe that strongly. But you see, here was an opportunity to remind clinicians and everyone else that just because someone dies where you aren't looking doesn't make it any less important. It makes perfect sense, though, for them to say, we want to maximize good results because that's something of moral value. There's nothing crazy about that. But the problem is it's going to lead to continuing inequalities. And again, why? Because the people who are in control of those inequalities are the ones who are continuing to benefit from them. In COVID-19, the increased risk occurs because socially disadvantaged persons are already going to be less healthy. And Emmanuel and his group's distribution design, which specifically for treatments now, privileges the powerful and unequally harms those who are least well off, means that those who could change the system have a vested interest in not changing it. That is, this was an opportunity to make those in power fight to have to make things more just in order to obtain what they wanted to have access to. It was an opportunity. Well, it was an opportunity lost. And the thing is, they didn't even have to reinvent the wheel here. There were at least two sources they could have started with. Here's from 2010, the Minnesota Pandemic Ethics Project produced reports providing guidance for basically this exact thing, preparing for a pandemic and guiding resource distribution in the case that the needs in a pandemic overwhelm supply. They explicitly refer to the challenge of just distribution in the case of needing to ration resources. And they make public engagement in the process of devising the distribution plan and issues of social justice specific points of importance. And Emmanuel and his group could easily have followed along with this. And this is a starting point. The reports from the Pandemic Ethics Project they're a good starting effort to produce public policy with an aim of that policy being justice in distribution that takes into account the needs of those the least well off. They want three goals: protect population health, protect the public safety, but the third one, strive for fairness and protect against systematic unfairness. Obviously, what specific policies you get depends on how you balance those three things against each other, but they are very clear on here are some very specific things that we need to do in order to protect against systematic unfairness: reduce significant group differences in mortality and serious morbidity, make reasonable efforts to remove barriers to access, reasonable efforts to reciprocate to groups accepting high risk in the service and others. And of course, one of those groups is clinicians, but another group accepting high risk in the service of others would be, workers at a popular chain store who I won't identify, the chain store. I'll just tell you the t-shirts they were all wearing for about a week before somebody realized it was a really bad idea. They were all wearing Mick Hero t-shirts. Well, they're too accepting high risk in the service of others. And we need to make sure, and this is again, Minnesota Pandemic Ethics Project, to reject strategies that exacerbate health disparities. So if we designed a policy based on this structure, we would have at least the idea of targeted universalism built right into it. And if that wasn't enough, they could also have looked at, our best example of carefully thinking about distributing scarce resources, organ distribution. Now, we can't really use the tools that are used in organ distribution, but we can at least see why they're there and what we might be able to do to imitate that. Organ distribution absolutely is guided by an attempt to maximize the years of life from an organ. That's their goal. But they have at least two features included in the guidelines for who gets access to a particular organ, which will modify that and perhaps give persons who would otherwise not be able to maximize the years of life still get good access to an organ. One of those is prior live organ donors are given very strong preference, and that's only available to people who actually could be prior live organ donors. Not everybody is, not everybody's an acceptable candidate for organ donation. But they also talk about time on the list. And time is something that can flatten the inequalities that make some people more likely and some people less likely to maximize years of life. I think the reason for putting time on the list is an attempt to put an element of fairness into the system. Any person, regardless of how hard it's going to be to match a kidney to them, regardless of how likely they are to survive for very long after getting one, any person can make, and let's use kidneys as the example, can make it to the top of the list and receive an organ. Because lifespans between 5 and 10 years on dialysis are reasonably possible. I wouldn't say pleasant, but certainly possible. And if that's true, time on the list is going to be the dominant factor in whether or not you are the best candidate for a kidney. When I say best, I don't mean the one that will maximize years of life from the organ. I mean one that will get it nonetheless, because time on the list helps equalize. So even in a system that's heavily weighted towards producing the most life years, they're trying to put a serious method to equalize opportunity in there. Now, I freely admit, you can't do that in COVID-19 triage. There's no way to do that. There's nothing like time on the list that you can use. And things that you might use like first come, first serve are terrible. So Emmanuel and his group reject that for reasons. They could give better reasons for why they reject it, but they reject it. Here's the thing though. What they produced doesn't even have the protections that we've got in organ donation or the ideas that are put forth in the Minnesota Pandemic Ethics Project. They only focus on maximizing the benefit, which means what we've already seen. People who are worse off are going to continue to be worse off. And this is not, again, remember, I'm mad about this. This is not a matter of theoretical dispute. This is a moral moment. Yancey says it better than I can. It should be unconscionable for the rate of death for African Americans to be as much higher as it was in Chicago, but even if not that much, it should be unconscionable that people are dying at a higher rate because they are African American or because they are poor. And this is a moment of ethical reckoning. This is not a time where policy is morally neutral. Maybe that's never true, but it's certainly not true here. And here's the thing. COVID-19 will end eventually. Healthcare disparities will persist unless we do something about them. Well, they will continue to persist, I'm sure, but we can definitely make them better. And a pandemic can give us the opportunity as a society to make real, lasting changes. Real changes that what I think would be otherwise impossible to do in the normal order of things, right? What we're doing right now, what we now take as the normal way to interact with people was ridiculous. Nobody did this before COVID-19. We'll make huge changes in society if we have to. And we could take this opportunity to make healthcare disparities and inequalities better, or we could fail our society again. And I wish Emmanuel had led the way, but he didn't. So we're just going to have to do it without him. These are problems that we have to address. And if the old guard ain't doing it, then we need to get the new guard do it. Maybe I should stop here while I'm on a milk crate, waving my hands around, ranting, and ask if anyone has any questions. I can go on. Perhaps it's obvious I can go on, but let me pause and give someone else a chance.
And before we get to formal questions, I just want to help for those students or residents who are joining us in terms of background. That Zeke Emanuel is the acknowledged architect of the Affordable Care Act, which again was a proposed political and logistical means of dealing with health equity, but without really dealing with the fundamental problems. He also wrote the recent article, Why I Hope to Die at 75, a convenient Soylent Green argument of how to go ahead and no longer spend those unnecessary resources on elders. He had a lot of blowback for that. And very importantly, he wrote he wrote a book called The Ends of Human Life, which I reviewed. It was fairly dismal in that it was a proposal to collect people together in community health plans Unfortunately, it was going to be a self-selected, let's all get together and we will pick who is in our baseball team, which meant you would have the self-selection as well as the cherry picking of shunning those you didn't include on your team, so that these healthcare plans could then have a magnification of the inequities that we currently see in healthcare. So I want to applaud Dr. Hanson for pointing out that, yeah, it's great to go ahead and have a nice academic article that talks about justice. But if you're not talking about injustice before you talk about justice, you really aren't making any points with anybody.
David, Paul, if I could just ask Dr. Hanson one question. Yeah, Paul,
Go ahead, take it away.
Yeah, outstanding discussion, disclosure. So I'm a surgeon. And again, at least my research has been on healthcare disparity and socioeconomic determinants of health. So I come from a similar perspective.
Excellent.
The major challenge I had from an operational level, and certainly not from a system-based level, was really in the lay press from the Detroit hospitals, quote unquote, the triage system. Again, if there weren't supplies that were available to go ahead and triage people, as far as almost a lifeboat, who lives, who dies philosophy. The thing that I didn't see discussed over this was, at some level, was this an abdication of responsibility? From a surgical perspective, our basic cancer surgery, our major premise is autonomy and empowering patients with autonomy. Again, at some level, if resources are scarce, and again, I can't provide a service over here, then there's always MD Anderson. We can get the patient over there. The concern for an operational level is that the individual hospital, if they take the perspective, if we don't have enough lifeboat, and again, this is just thoughts, does that at some level abdicate responsibility? We could take to Louisiana, the state. Frankly, if we don't have enough resources in New Orleans, should we be looking at a statewide system? If there's not enough resources in the state, should we look at a nationwide system? And again, if there's not enough resources in the nation, is that the time to bring systemic change as far as triaging? Is it ethical to have triage at an individual hospital level is the question from your perspective.
And well, but aren't you already triaging when you're saying, well, we have to send this person off to MD Anderson or this person off to Louisiana State?
But again, from a triage, at least from a cancer, we're not withholding care. So again, there's opportunities to go ahead and do that.
Okay, so
again, if we don't afford the opportunity, Anderson could say they can't get in because of this. But again, we're offering people options in terms of autonomy. And that was the major operational concern, is I didn't feel that we were doing due diligence, that until we have to make really hard decisions as far as you don't have treatment because there's no resources, is this approach an abdication of responsibility to having the individual hospitals make the decision when these questions in terms of triage should be a national question?
Right. So I'll agree with that. Right. So if we're going to try to do triage as a way to justly distribute scarce resources, we can't do it piecemeal at a hospital level. And the reason is every hospital is going to do it differently. And the whole point of justice is that we're going to treat similar cases similarly. We're going to try and have a policy which is going to treat you the same way, whether or not you go into MD Anderson, whether or not you go into Tulane, whether or not you go into LSU. That means that we can't do it on a piecemeal basis, because what will happen is, instead of having a just distribution that way, we'll actually just make the injustice different. People will be treated differently depending on which hospital they're at.
Mm-hmm.
And so, yes, we have to have it. Maybe it doesn't have to be nationwide, but it certainly has to be at least statewide. And for something like this that's going to impact the nation, yeah, nationwide would be the right way to be thinking about this. And I do take it that that was what they were trying to implement with this article, was here's how we ought to be doing this. Again, when Zeke Emanuel speaks, people listen. So that was what I think they were doing. But yes, I would be very wary of saying we should be implementing this piecemeal at the hospital level without any kind of guidance from above, because we'll actually completely fail to do what we were trying to do, justly distribute resources. We'll end up doing it unjustly based on where you are and who sees you when you come in and so on.
Thank you.
Oh, certainly. Thank you.
Dr. Hanson, may I?
Please.
Go ahead, Valerie.
My name is Valerie Holiday, Dr. Hanson. My background, I'm the humanities side of the program, so I'm not a clinician like Paul. my question, or it's not really a question, I'm actually just sharing this with you because I'm interested in philosophy as a discipline and so forth. And so I'm working on this idea that utilitarianism itself is actually a white ethics. I mean, it comes from the Enlightenment and it comes from the, so I guess if I could get you to comment, there's a text, shucks, I just pulled it out. There's a book called The Enlightenment That Failed, and that's what I'm reading now. And John Stuart Mill falls right in
squarely, yeah.
where that was not actually democratic what got exported out, into North America. So would you want to comment on that, or is that somewhere you would go with this?
I find that intriguing. Here's my only concern. Yep, that's probably an accurate description of utilitarianism. I'm also having trouble coming up with a theory that we generally use that isn't going to be tarred with that same brush, and correctly so, right? I mean, a lot of our theories come out of the Enlightenment period. Maybe the best answer might be that the theories that started more recently with an intentionally critical angle on these theories, and here I'm thinking specifically care theory and feminist ethics, they might be the ones which would be the least likely to fall victim to that, precisely because they're premised on questioning the underlying assumptions that we might have from the Enlightenment. So sure, I mean, I'm certainly not going to be defending utilitarianism, although I'll defend it a lot more than some people will, but it's it fails along with a lot of other things, that same challenge of, well, are you basically assuming a white-based, wealth-based, male-based way of looking at things? Yeah, they all are. And so perhaps the theories that start by saying, let's criticize that first and see what comes out of that, those might be the best ways to start looking at things.
Thank you. I'd love to, I have more to say, but.
Great. I'd love to talk about it, yeah.
Dr. Hanson,
Yes.
I wanted to ask you a question. My name is Sonia Malhotra. I'm the Director of Palliative Medicine at University Medical Center, which is our region's safety net hospital, where we see a lot of inequities and disparities in healthcare. My question to you is, now that we have vaccines, sort of what are your thoughts on a sort of just way to promote vaccines? I know this is a very loaded and large question. There was recently the HBCUs in the area, Dillard and Xavier, their presidents came together to put out a joint statement to recruit students to participate in vaccine trials. And I'm just wondering what your thoughts are on that.
I mean, this is, yeah, you're right, huge question. How do we talk about issues of justice in research, broadly speaking, which has its own history of being extremely problematic and extremely unjust in the way that it has functioned as well, would be is a huge question. So how might we go about talking about justice in this big question of vaccine research? I gotta say, the idea that the historically Black colleges are getting involved in saying, let us get our students involved in this, the kind of community engagement that entails, would probably be the best way to try and move forward in these discussions with some hope of getting a reasonably just understanding of what's going on. I mean, that's been the problem all along. If we're talking about where did the Enlightenment fail? If it had failed because this is, wealthy landed men talking to each other in academic silos, well, the approach to that that's going to change that is going to be community engagement with specifically the people who are going to need to be a part of this if we're going to get anything like a just distribution. mean, I'm very glad to hear that that's part of what's going on in getting enrollments into vaccine trials, because we're not going to get there. We're not going to get anything close to justice until we get a lot more people talking about it than people that look like me and Zeke. I don't know if that's a good answer, but it's. I mean, I love that that's part of what's happening.
No, I really appreciate your answer. I will tell you there was controversy on both sides. I think there's definitely an appreciation from, inclusion of the community. I think the way in which it was put out, there was also some controversy from our local African-American communities.
Okay, yeah. Yeah. And there is a minefield that's been built for generations that you have to work through if you're going to be dealing with how to interact with previously and still currently disadvantaged communities like the African American community and dealing with medical research. So yeah, working through a minefield is going to be tough.
I have to tell you, I presented that idea to two of my other institutions, the Utilitarianism White Ethics, and I have gotten 3 very different responses. Yours was the only one that was positive. No one liked it, black or white.
Yeah, but gosh darn it, you're right. I mean, maybe they didn't like the label, but you're right that where this comes from is a place, not the universal place that it thinks it is, but a place of thinking about things. Are there other questions?
Yeah, I have a quick question. So, Nate Stout, I'm a faculty member in the program for medical ethics and human values and medical ethicist at the VA hospital here. So I think I generally agree with you, and I certainly agree that it's unconscionable, right? The health disparities that occur among poor and Black communities in America. So I guess though, so I do want to push back a little bit, right? So I'm just kind of thinking, I don't know. So I mean, first of all, so I'm not sure that that the Emanuel paper has made things worse to date, right? So I mean, we have similar numbers here in New Orleans in terms of hospitalization and everything like that. And at least if you take hospital administration at their word in the various institutions in the city, right? We haven't actually been rationing ventilators or anything like that. So I'm not sure that they've actually caused any further problems so far, right? Though I take your point that that potential to do so is there, right? But I'm also just kind of wondering what a different proposal would be, right? So I'm thinking of the average clinician or the people on a triage team at the hospital, and they're looking for some way to sort of devise how are we going to allocate resources or ventilators or dialysis machines, right? And looking at sort of objective medical markers as one way to do that. And I think that sort of takes some of the pressure off of the team to some extent, because they can say, look, this person is experiencing multiple system organ failure. They're not likely to benefit from a ventilator. And so we're better off giving that ventilator to someone else. And so I mean, that I can sort of, I guess I'm kind of just wondering what an alternate suggestion would look like, right? So, I mean, should we also be looking at whether this patient lives uptown New Orleans or they live in the upper 9th ward, right? I mean, is that going to be a factor in how we allocate a ventilator? And if so, I mean, what kind of additional stress is that going to put on the clinician who's actually extubating a patient who lives uptown and giving it to someone?
That's right. Okay, exactly. Right. And so when you say somebody who's in multi-system organ failure is not going to benefit from this, okay, right. So that person is in one category, the kind that's not going to benefit. But you have different persons who would benefit from it. And to be honest, that is one of the options that might be what you have to do, allocating a certain number of whether they be vaccines or various types of treatment and so on, for persons who are, as you say, from the upper 9th ward, persons who are both, from the poorer area of town and African American, add it up however you want. And of course, that's going to that's going to raise real difficulties for clinicians who are having to say, oh yes, we actually do have a ventilator, but you can't have it. And the anger that this would raise in persons of power who would surely complain about this being unfair because these resources aren't available to them. But I almost want to say that's a selling point of the approach, because then people in power would have real motivation to make sure that there are enough resources available, that things are more just for the next time through. I mean, I don't want to say things never change until the persons who can change them feel harm, but it certainly speeds things up. It shouldn't be true, but I mean, we got a lot of years of evidence showing that that's true. And you're right to say clinicians would have would almost certainly, okay, I won't go this far, but riot, right? Clinicians would have a terrible time doing that. And it's real easy for me to sit here as a philosopher who's not a clinician, who doesn't have to do this, to say, here's a thing that you might actually want to do. But again, this is a situation where we've got people who are dying because they, and by the way, it's not, right? You're right that we didn't actually hit the levels of ventilator dependency that we were having to deny people ventilators. We didn't hit that, and I don't think generally across the country we hit it. That was what Emmanuel and his group were afraid of, and at the time I was too. And though we've hit very high rates of infection and death, we don't seem to have dramatically overwhelmed the resources in any particular area. But if we did dramatically overwhelm the resources in any particular area, then you would already be saying to somebody, you don't have access to this, and you're going to die for lack of access to this. And in fact, and again, Zeke Emanuel has pointed this out, that's what we do in our healthcare system already. But we don't see them because they don't have insurance, so we don't see them in the hospital, or at least until way later in the situation. But again, that somebody's not, that we don't see somebody doesn't mean they're not dying for lack of this. So I mean, I agree completely. When you were, if you had to say to a group, what do we do to impose, if you had to say to a group, you're going to have to portion out these ventilators, and that means this group's not going to have access to it, that would make things explode. But that's almost a selling point, because then we actually get people talking about it. If, of course, we didn't do that so much as we had somebody arguing that back on March 23rd, then perhaps we wouldn't have the explosion, but we would still be having the argument about what should we do in these situations. And I'm very glad that we didn't run into the concerns that Emmanuel and I were both worried about at the time, that we were going to overwhelm the system. But I think we still have to ask the same questions.
Dr. Hanson, we're going to need to wrap up. I do want to add one point, and that is, at the time that this article was being written and published, there was a great deal of concern that there was going to be the invocation of these crisis standards of care. We were at the other facility across town where I am, and so I think the real push come to shove part of this had to do with the invocation of contingency standards of care, which is when things get really bad, we're going to move people, we're going to move equipment, we're going to turn wards into ICU beds, et cetera, because not only is it an equipment issue, it's also a personnel issue that we run short of. And yet with that, we got to that point where we got almost to the breaking point, but didn't break. And in a way, I mean, one of my own pet beliefs has been the only way we will ever see comprehensive healthcare reform in the United States is if there were a pandemic. I've said this for years.
Collapse.
We did not get to that point of breaking the system. We just bent it badly. And unfortunately, the solutions that were offered in that paper did not help if we had hit that breaking point. But I want to thank you for your analysis, and I want to thank you for your discussion today. So with that, I want to give you a thank you, and to also, if others have specific things they would like to email Dr. Hanson, it is stephen.hanson@louisville.edu.
That
All
is
right?
correct. Yep.
All right, great. Thank you all very much.
Wonderful. Thank you all.
All right, bye-bye now.
Thank you.